Okay, so as you guys all know, liver transplant patients can be some of the most challenging patients to take care of in the immediate postoperative period. So I asked Dr. Anderson to come and give us a little talk on caring for these folks in the immediate postoperative period. So he was kind enough to join us. Much appreciated.
Yeah.
Dr. Anderson, fire away.
Thanks for having me. I'm Chris Anderson, for those who don't know me. I'm one of the transplant surgeons. I don't want to disappoint anyone, but if you want to know my methods of floating swans and reading numbers, that lecture actually costs money, so we're not going to cover that today. But I want to cover sort of some generalized topics, and we'll go sort of at a pace. This is not all-inclusive, so throw your hands up, ask some questions, and we'll shoot from the hip, because I'm sure that I can't possibly think of every situation to cover that you guys may be in. So liver transplantation often starts with someone with a belly full of ascites, and you remove a very small liver out of that big belly, and you put a healthy liver in it. And this is an operative photo of actually of a living donor, left hemiliver, right hemiliver. So part of understanding how to take care of the patients is always a little bit of where we came from. The first liver transplant was the first attempted human liver transplant was in 1963 by Dr. Starzl in Colorado. It didn't work. The 3-year-old child with biliary atresia died on the table from hemorrhage. Starzl attempted 6 more that same year. They all died. And a moratorium was put on the operation worldwide, if you will. And more lab work was done. Starzl reattempted it in '67. This patient lived, and he went on to do 7 more, and 7 of the first 8 were long-term survivors. One of whom, I believe, several years ago was still alive up to today. And so some of the advancements we've made in liver transplant and transplant in general is the first real preservation solution, which was the Euro-Collins solution in '74. And in '79 was the first calcineurin inhibitor, cyclosporin. Before that, immunosuppression was largely steroid-based, with some antimetabolites. The first reduced-sized liver transplant was in the early '80s in Belgium, and then the first split liver. And for those of you who don't know, the difference in a reduced size and a split, they're both deceased donors. A reduced size organ basically means we take a whole organ, cut it down to the size we need it. It's often going into a small adult or a child, and it's often we're cutting down to the left side. The other piece is discarded. A split, we're anatomically preserving both pieces, usually using a segment 2-3 graft in a baby and a right tricep graft in an adult. Wisconsin solution, or UW solution, surely everyone's heard of, actually came about in '87, and that was, a lot of people consider that right up there with cyclosporin as far as advances in the transplant field, because it was the first legitimate long-term preservation solution. And the fact that we still use it today, and there's really only one other equal competitor today, stands up for how good it was. The first living donor was done in Chicago in 1989 for a child. It was a segment 2-3 graft. Prograft, or tacrolimus, in 1992 was developed. And probably the most recent big change was in 2002 when the MELD-PELD system was implemented. We'll talk a little bit about that system, but before that time, livers were allocated a little bit on waiting time and a little bit on if the patient was in the ICU. So you could bring the patient home, from home, perfectly healthy, put them in an ICU bed, and all of a sudden they go to the top of the list. So that was not necessarily a great system. Common indications that you guys will see us do transplants for is alcoholic liver disease, viral hepatitis, obviously hepatitis C, the vast majority of those. We still do a few hepatitis Bs. Hepatitis C is the leading indication for liver transplant, followed closely by combo hep C alcohol. Cholestatic liver disease, primary sclerosing cholangitis, primary biliary cirrhosis, those numbers have remained stable over the years and still represent a significant portion. That cholestatic liver disease or biliary atresia is the largest, is the leading cause in children. Malignancy, you guys see us do a lot of livers for hepatocellular carcinoma, especially when it coexists with hepatitis C. And we won't get into the ins and outs of the criteria there, but for selected patients, that's the treatment of choice for HCC. Metabolic disorders, alpha-1 antitrypsin deficiency, cystic fibrosis liver disease, OTC deficiency, and a number of other metabolic disorders can be cured with liver transplant. And then we see probably 2, 3, 4-year fulminant hepatic failures. Some of them drug-induced, some of them idiopathic or cryptogenic.
Hey, Chris, are many, besides HCC, what about metastatic disease? Is this becoming a...
So there is no transplantation for metastatic disease. The only metastatic cancer that can get a transplant today is Stephen Jobs, but he had neuroendocrine tumors. So there is a small subset of patients who have metastatic neuroendocrine tumor to the liver, and the tumor burden is such that they actually have a liver failure with no evidence of extrahepatic disease over a long period of observation. It is hotly debated if those patients benefit from a transplant or not, but it is an indication they can get transplanted. He is obviously the most popular, the one everyone reads about. The neuroendocrine tumor is an indication that comes up occasionally. To my knowledge, in the past 3 years, we've not done one. We've evaluated one patient who actually his liver failure from disease burden was so poor he never made it to the transplant. The MELD score, as I mentioned earlier, is how livers are allocated. It's not based on waiting time, it's based on how sick you are. The MELD stands for myeloid stage liver disease. It's based on creatinine, bilirubin, and coagulopathy, so INR. This was originally developed for patients undergoing TIPS to figure out what their risk of dying after a TIPS procedure was, but it actually correlates well with the overall 3-month mortality rate from liver disease. So the higher your MELD score, the higher your 3-month mortality rate without a transplant. And so that is why it's used to allocate livers. So it basically goes from 6 to 40. You can calculate numbers higher and lower, but 6 to 40 is the range that's recognized. We give MELD exception points. There are patients with hepatocellular carcinoma who fit into the transplantation criteria, often called Milan criteria. They will be allocated 22 exception points, so that we've sort of estimated that their mortality risk from cancer is about equivalent to that MELD score. Cholangiocarcinoma in highly selected patients with unresectable small tumor liver-only hyalocholangiocarcinoma who've undergone neoadjuvant chemoradiation therapy, jumped through a lot of hurdles, can get a transplant for cholangiocarcinoma. So our institution is one of probably 4 or 5 in the U.S. that actually has one of these protocols.